Hello, good morning, and welcome to the Mayo Healthcare breakfast session. Thank you all for getting out of bed so early. I'm sure we're going to have a very worthwhile talk now, which will start your day well. Mayo Healthcare has sponsored this session. We are in booth 2 in the main trade area, so please come and visit us and have a talk to us later in the day. So without further ado, I'd like to introduce Dr. Catherine Murphy. Catherine is a registered nurse and an infection control practitioner with many years of experience. She has a PhD in epidemiology, and with her wealth of knowledge, she has worked with the CDC. She has also worked during the SARS outbreak within the Asia area, and has led up many projects with New South Wales Health as well as Queensland Health, and has worked clinically with infection prevention for many years. Kath also was the first outside of the United States president of the Association for Practitioners in Infection Control. So it's with great pleasure that I welcome Catherine Murphy to the stage for her presentation on chlorhexidine. Is it time to defend or defriend? Thank you very much, Catherine.
Thank you, Joy, for that lovely introduction, and good morning, everybody. It's really my pleasure to come down here, but I have to say that the Walk on the Wild Side themes had me worried for a few weeks as I've been trying to prepare, because I wasn't quite sure what it meant until I transited through Sydney Airport yesterday and had a look at the smoke and the smog and everything that's going on there, and it's really quite concerning. So I was rather pleased to get here last night. Anyway, I'm also very grateful to Mayo Healthcare for the opportunity to present, and to the organisers of ANZICS and the ACCCN for the invitation, so thank you for that. Before I do go on with the main body of my presentation, I'd just like to draw your attention to this disclaimer, and particularly the bottom line that indicates that I am in this capacity a casual consultant to Mayo Healthcare. But having that out of the way, we now have to get down to the serious work, and in the next 45 minutes or so, cover these 4 areas. I want to talk to you this morning about the incidence of catheter-related bloodstream infections, because you may or may not be aware of that topic. I want to talk to you about the pathophysiology that's involved, some of the preventability around those infections that we know of from the evidence, and then talk about the somewhat controversial issue around chlorhexidine and its use as an infection prevention intervention in 2013, and then touch upon the issue of sensitivity and how safe chlorhexidine is to use. I hope that through my use of evidence, my research background, my recent clinical work as part of the Gold Coast Infection Control team, and my experiences around the world will give you a very balanced and real-world view of the issue. So let's start off and look at this incidence of pathophysiology and some of the costs that are involved in central line-associated bloodstream infection. First of all, we need to know that we really know a little bit about the use of central lines, and that's because around the world people don't uniformly collect data and report their infections in exactly the same way. But we also know that the use of central lines is extensive around the world, and in fact in Europe about 50% of all patients going into an intensive care unit will get a central line. From Europe they report that the attributable mortality, so therefore death associated with a central line associated bloodstream infection, can be between 0 to 11.5%. We know in Europe that the additional length of stay is between 9 to 12 days. Some of those may be intensive care days. In Australia, recent work from McLaws, from health economists, from even Hand Hygiene Australia gives me a different picture. And what we see here is that about 17% of all patients going into intensive care units in this country will get a central venous catheter put in. Now, I don't have the actual figures for how many catheters that is for the country, and I apologise for that. I would have liked to have done the extrapolation. But I know that in New South Wales, and we could probably just think of New South Wales and then divide it for your own states, there are about 17,000 catheters every year that are inserted. And their current infection rate is about 1.2 per 1,000 catheter days. That's great because we know that information. But what I think is probably more concerning to me as an infection preventionist is the issue around non-compliance. And we know that non-compliance around the well-described central line-associated bloodstream infection prevention bundles is far less than 100%. In fact, for the clinical components or the clinician components of that, compliance is between 75% and 90%, and we know that hand hygiene compliance across the country, and it's been well studied now for a long time, is sitting at only about 78%. So when I see those risk factors starting to add up, in that I see a large number of people with an invasive device being assaulted by an invasive device, amongst clinicians who, because generally of problems in the system, not problems in the individual, are unable to comply with some of the issues around either insertion management, and then we see those same clinicians having difficulty performing hand hygiene 100% of the time. To me, it sets up a perfect algorithm for catheter-related central line-associated bloodstream infections, and I do use those terms interchangeably, and it's just because my head's sometimes in Australia and sometimes overseas. So it worries me at a very basic level because of those issues, a lot of use and not 100% compliance. We also don't yet understand very well in Australia very much about line management, how we're securing these devices, how we access them and how we manage them. And we do understand that probably at unit-based levels, but in terms of, comprehensive studies, they're not yet fully published, although I suspect that Claire Rickards and our esteemed colleagues, other esteemed colleagues, are working hard to get that to the forefront. So patients come in with intrinsic risk factors, and the system gives them exposes them to extrinsic risk. And we need to manage both of those types of risk to prevent them getting a central line-associated bloodstream infection. And some of those risks include any underlying diseases that they have, whether or not they're immunocompromised, how long they've been in the hospital or the unit before they've had a device inserted. And of course, the longer that they're in hospital or they've been exposed to the healthcare setting, the greater their chance of being colonised across their skin with organisms that are potentially pathogenic. The insertion site, we know, is problematic, and different parts of the body bring different opportunities for colonised organisms to migrate and subsequently cause infection. How the catheter is managed in terms of how long it remains in situ, what the practice is of those clinicians who are accessing the line, all of those things are extrinsic, and they add and contribute to the risk, as does the use of antibiotics during and subsequent to the catheterisation. Now, I'm sure that you are well familiar with this slide, so I won't dwell on it, and that's not an ICU pun in any way, but I'm going to just quickly go over it and say that we know many infections for central lines are associated with pathogens that migrate along the external surface of the catheter. That form of, that mechanism for infection is more common in catheters that are in situ less than 7 days. We know that for infection that occurs after a catheter that's been in place for greater than 10 days is usually from hub contamination, and it then goes on and subsequently causes intraluminal contamination. And then there are other less common causes of infection or mechanisms which include seeding from another source in the body or infusion of a contaminated solution. But these are the main ways that we know infection happens or is at least set up. And that's certainly how we've thought about infection for, you know, the last 20 or so years since this was first proposed. And there's been some more recent work and still evolving work that I heard about in great detail even just a few days ago. So I've tried to incorporate that as well, and that's a bit of stuff around biofilm. So when I come into an intensive care unit, and I'm always welcomed into the intensive care units, but I'm always a bit scared to go in there because you're an intimidating lot, and there's many more of you than there are infection preventionists. If I'm looking for things to prevent this sort of infection, or if I go into an anaesthetic bay, I'd look, of course, at the way that you insert and what your technique is like, the way that you subscribe to asepsis. And then I would look, of course, at how you handle and maintain these lines. And hopefully I would see units and centres that are committed to the removal of these lines as soon as they possibly can, because if we can remove them, then we eliminate the issue. Because for each hour and for each day that one of these devices invades a human body, there is a potential for biofilm development. Now, I don't profess to be a biofilm expert, so I'm not going to go into it in any extensive detail, other than to say that biofilm exists all around us. It's on our teeth, it's in the environment, which makes cleaning of the environment difficult. For invasive devices like this, what happens is that the body's exposed to a foreign object, which is, in this case, the central line, and then bacteria attach to that central line because of irregularities in the surface of the device. We've generally thought that that attachment of bacteria has been at about 24 hours, but we now know that it can happen even as quickly as 2 hours after insertion of the device. And then the bacteria that attach and form this biofilm are very social, they're very gregarious, and they invite other bacteria to come down and play with them, and then they proceed to form this filthy biofilm, which is resistant to all host defences, including the typical white blood cell responses that we would have. Now, what's a critical factor for me, looking at this from an infection control point of view, is that Staphylococcus love biofilm. They're highly attracted to it, and we know that Staphylococcus is commonly on our hands. We know that Staph epidermidis is often associated with central line bloodstream infections. We know that Staph aureus is also associated with them, as are the coag-negative staphylococci. So it's concerning that biofilm develops, and I hope that nanotechnologies and other developments in the future will help us address this whole issue of biofilm, how to prevent it. In case you don't believe me, or just for a little bit of graphic intervention, let me show you electron scan microscopy of Pseudomonas on a silicon catheter, 100% silicon catheter. This is what it looks like at 2 hours. If we go forward 16 hours, you can see at the same magnification much more dense formation of these colonies. So it's a very real issue, and whilst we can't see it with the naked eye, we need to respect that this is what's going on whilst that catheter remains in situ. So insertion's really, really important. Cleaning of the skin, you know, and skin antisepsis is critical, because all catheters will eventually become colonised after they've been inserted. And the probability of a patient with a catheter in situ becoming infected is actually proportional to the number of microbes that are multiplying on the catheter surface. So we've invested many, many hours and lots of work, and particularly the group K, you've been part of it. I know that New South Wales were very part of it. Gabby Hanlon and her group and the ANZICS group spent so much time and effort coming out with that comprehensive report. And I think that we can say that intensive care unit nurses and doctors did a far better job and met the unmet need that we'd had in Australia around improving insertion of these devices. So thank you from the infection control community for that work. It thrills me and amuses me slightly to see this recommendation, and my amusement is not a bad form of amusement. It's around the word easy, And these are ANZICS 8 easy steps to CLABSI prevention. They are absolutely the appropriate steps to take. And why I'm amused is that I don't think in any way that any of them are actually easy, because of the issues of non-compliance and sometimes because of the issues around systems that make it difficult for clinicians not to do the right thing. So all of these steps, if followed, should significantly reduce the risk of a patient developing a central line associated bloodstream infection. But we know that we have holes in our systems in terms of non-compliance, and we know that we're also fighting an uphill battle against biofilm, which makes it incredibly difficult. So I guess that one of my scientific questions is, even if we followed these 8 easy steps and we had a bit of luck along the way and we had full compliance, could we actually ever really prevent these infections? Now, remarkably, or not, there are certainly several hospitals in the United States who have been able to get their central line associated bloodstream infections to 0 and maintain them. And I think it's good for us to focus on that and look at what they do and what they do consistently over long periods of time to maintain those 0 rates. Because the simple facts are that probably about 2.5% of patients become infected if they have a central line in. These infections are caused by a range of pathogenic organisms, both gram-positive and gram-negative bacteria. They're also caused by fungus, so common things that we'd see, Candida albicans being one of them. Normal skin flora is problematic, and they're listed there. I've talked about them before. What's concerning for us now is that in one study, it was multiple resistant organisms that accounted for almost 3/4 of the blood that was cultured from patients with central line associated bloodstream infections. And we are not getting any better at preventing multiple resistant organisms, which is why we're now throwing lots of intellect and lots of cold hard government cash towards the issue of antimicrobial stewardship. So this is concerning, and we need to address it in the ways that we are, and probably in some more innovative ways as well. Because these central line or catheter-related bloodstream infections obviously cause increased cost. No one will argue that with me, I hope, and they certainly cause patient morbidity. And they're problematic because some studies have said to us that in an intensive care unit, these lines may be accessed up to 16 times a shift. I'd suspect that that's probably an underestimation, but to do the observational studies of that would be a really complex study, and perhaps it's something that others may do over time. The treatment costs are incredible, and if a person in Australia gets a central line associated bloodstream infection, it's been estimated that they'll spend about another 2.5 days in an intensive care unit, and that those intensive care unit costs on old money were about $3,000 a day, and I think that they're probably a little higher than that now. So you can do that maths there. If they spend another 7.5 days excess in a ward bed at just under $1,000 a day, that's just the cost for their accommodation. So it's like extending their holiday, but it's a huge amount of money that's wasted. It also blocks up the hospital beds so that the hospital can't put their throughput through. And then these figures obviously don't include other things like treatment costs, medication, any diagnostic tests that happen, the costs of staffing and all those other things. Concerning to me also is the ecological cost or the microbiological cost, which is this additional use of antibiotics. So if we can avoid use of antibiotics when they're unneeded, that's always a good thing. So it's not always just about the dollar cost, it's about this ecological cost. And then, most importantly, although my slide sequence doesn't suggest this, is what's the human cost? Now, I have to tell you, living on the wild side or the dark side or wherever we are now, I do lead a somewhat risky life in some ways, and I don't particularly like it when I see my name on a grave anywhere, but I grabbed it because it's been a good slide to use to hopefully get people to laugh, but there's not much humour in this room this morning, so don't feel compelled. Anyway, I put it up there as a very sobering reminder that death does happen from these infections, and that whilst between 1% and 2% of people will get these infections from having the lines in, if I step back and I look at this as a healthcare worker, I think, how does this actually impact the families of all those Australians who each year will develop a central line associated bloodstream infection? There's lots of families. There's about 3,500 families whose loved ones that they care for will develop these sorts of infections, and this is what you're telling me in the public domain from ANZICS website. So if I throw in there the 1% attributable mortality, I know that from those families, 35 of them won't have their relative or their loved one survive. And that's from an infection that's entirely preventable. So hopefully you get the picture, and I know that in some ways I'm preaching to the converted, so I apologise for that, but even if I've been able to help you craft an argument as you're trying to get your peers to do the right thing, or if you may have one of those momentary lapses, or if you need to put a business case to your executive as to why you need to implement particular measures or particular strategies or even particular technologies to reduce this infection, I hope that that sort of data will help you craft that argument. Because I know in Australia we've worked very hard at trying to reduce these infections. In fact, in the last few years, millions of dollars of our taxpayer dollars have been put into preventing these and other sorts of healthcare associated infections. We've also put in millions of hours of intellect, both at government level and high level committees, the work of the Australian Commission on Safety and Quality. We're in a situation now in Australia very much like where the US was about 10 years ago, where we're getting more media interest in infections and we're getting a public that's becoming increasingly aware. And as I was waking up this morning, I was thinking infection control like I do most mornings, and that's sad. But I was thinking about how a recent trend in the US is now for patients to have, or their families, to place a GoPro camera above the patient's bed, and they film most of the patient's admission, so that when they come out of the hospital, if they see an incorrect delivery of care or some care that is deviant from that which we know is best practice, they actually have it on film. And I think that Australia would at some stage most likely go down that route. Now, whether we ever get to the point where we voluntarily film someone's entire hospitalisation and let them take it home on a silicon chip, who knows? But I think that our levels of accountability, if you read around this issue on patient safety, have to be raised, and we need to be very aware of them, even from our own positions of potential legal involvement. I think that clinicians in Australia these days are exhausted, and it's hard work working in a hospital. I don't know how you guys do it day after day, and I commend you quite seriously for it. 18 months working in Robina Hospital and the Gold Coast healthcare system was as much as I could take recently, and I left because I could make a bigger difference elsewhere. Clinicians are tired. Sometimes I think that we've exhausted many of the avenues that are available to us in terms of policy and guideline, or we've become immune to them and we no longer see them for the importance. The academics, there's quite a lot of work going on academically in Australia around this whole issue and around infusion therapy, and that's very exciting. The infection prevention community, it's in a state of flux is probably the most polite way to describe it, but it's great that we've been able to partner in the last few years with groups like yours to come up with some collaborative approaches to preventing central line associated bloodstream infection and hopefully others in the future. So, not really pessimistically, in fact, with a lot of optimism, my personal belief is that the remaining solutions we have to address healthcare associated problems will be technology driven. So whether they will be around measuring accountabilities or whether they will be around fabulous new research and development that is currently underway that we don't even know about, we are in probably for a more interesting ride. And to do that, part of our job is to welcome medical industry to the infection prevention table and to welcome them as legitimate partners and providers of solutions to some of the horrid clinical issues that we're facing, and some of the things like biofilm that we can't prevent despite even 100% compliance with insertion and management. So I call medical industry equal partners, and I understand that they're commercially driven, but guess what? Hospitals are also commercially driven and politicians are politically driven, and I can say that because I worked for a long time in New South Wales Health Department. So we're all driven by different things. We have a set of current beliefs and focus. I think that around the world we would agree that central line associated bloodstream infection is possible to be prevented, but to get that prevention we need very clear policy and very clear guidelines that people can actually comply with. And compliance with those guidelines involves investment. So investment in training, investment in education, investment in technologies. It involves continual application of quality improvement initiatives, which requires energy and focus. It also requires good governance and accountability. So that is all about things like being able to stop an insertion that's not going as it should. It's about training people how to stop that insertion in a way that's not embarrassing to any of the clinicians, but clearly articulates the importance of stopping at that point and not continuing if a corner's been cut inadvertently. And it needs good clinician compliance. Those things will come. I think we are working well towards them, and hand hygiene and the ways that we've been working on hand hygiene has been a good benchmark and a good learning tool for us. Not only do we need to do those things because we come from a place of caring, we now have the wonderful national safety and quality standards that have been put out by the Australian Commission on Safety and Quality. And these standards, all 10 of them, have made a big difference to the way you perform your work, I'm sure. Vascular access fits in with about 6 of these standards. Very obviously, there's a relationship between good governance and having systems in place to run it. There's clearly a role for the prevention of infection associated with standard 3. And then there are the issues around medication safety, identifying the patient, the administration of blood and blood products, and then also responding to clinical deterioration. Now, this is important because under the current mandatory accreditation system, hospitals have to demonstrate that they're meeting all of these standards. So vascular access is a good example that you could show to accreditation teams that your hospital or your unit is seriously committed to the spirit and the intention of these new national standards. So I know that some hospitals in Australia have done such, and I'm going to share their experience with you right here. So this is my congratulations and kudos to the team at Cabrini, and particularly these two who are the nursing unit manager in anaesthetics and the director of the anaesthetic department, who decided to embrace the new national standards by doing a few things. They pulled together a team and took a team approach to really look at their methods of preventing CLABSI within the anaesthetic department. And so they came up with education, they came up with development of an insertion bundle, so they redesigned their process, made it smarter and easier for them to comply with the evidence and the recommended guideline practice. So they've introduced and seriously addressed the issues of skin prep and skin antisepsis, and they've done that through introduction of a 2% chlorhexidine antiseptic. They have introduced the use routinely of the chlorhexidine-impregnated central venous catheters, and they've introduced routine use of chlorhexidine-impregnated dressings for their central lines. And then they have also uniformly introduced the use of a specific wound dressing. Now, they do note the issue of chlorhexidine sensitivity and have alternatives available when patients have known sensitivity to chlorhexidine. And that, of course, gives me a segue into the next part of the talk and should give you a hint around where we're heading. But it also shows us that technology can drive solutions to central line-associated bloodstream infection. And some of the technologies that we've had the good fortune to see in the last 10 years particularly have been much more easily available applications of skin prep. So we've had, you know, the sticks that are impregnated is an example of them. You've had the issue of ultrasound to guide insertion of your central lines. We've had development and redesign of new devices to secure these central lines, because we know that if the devices secure that, also reduces risk of infection. We've had a range, and a complicated range, of needleless connectors that have been engineered and re-engineered and continuing to be re-engineered until we find ones that are safe for both patients in terms of reducing or eliminating additional risk of infection, and are also safe for staff to reduce needle stick injury events. We've also had other technologies in terms of these antiseptic impregnated dressings. The question of biofilm and whether or not we've reached the technological point for biofilm is still a little unanswered, and I guess that it will be through nanotechnologies and perhaps through continually improving device composition and design, including coating, that we'll be able to address this biofilm issue, which really is the elephant in the room, in my mind anyway. So antiseptic and antimicrobial catheters have been around for a long time. They're not actually that new. And I now want to shift the focus of this presentation and start talking about the use of chlorhexidine and chlorhexidine-coated venous central catheters. So they have been around since about 1990. They, in their first iterations, were externally coated and impregnated catheter surfaces that had a combination of SSD and chlorhexidine. So they were designed at that time and still to reduce catheter colonisation, and they demonstrated great in vitro broad spectrum efficiency, which is important if you go back to my slide around gram-positives, gram-negatives and fungi being causative pathogens for these types of infections. There's been many subsequent publications of additional in-laboratory and in real-world studies, as well as many economic studies that have looked at the efficacy and the opportunity cost of introducing these types of devices. What users wanted and what manufacturers were able to come up with was subsequent generations of these catheters that extended dwell time and actually improved the preventability of these catheters. So a lot of this we have to, I believe, pay homage to this fellow. Does anybody other than Joy or Amy or anyone who heard me speak in Sydney last week know who this guy is? Who was it? Dennis Mackey. Yeah, that's Dennis. He's absolutely, in my mind, been the father of infusion therapy and prevention of central line-associated bloodstream infections. And I took this image of Dennis in June when he was recounting his early career, and if you ever have a chance to talk to him about that, it's quite remarkable. But he did teach us a lot about insertion and asepsis, and particularly has done a lot of the investigative work around how these devices should be composed. Unfortunately, I would suspect he's probably coming to the end of his career, so I hope we can continue to pay homage to the work that he's done. And one of the most important papers that I think Dennis has ever published is this one, which in 2005 did a review of whether or not antimicrobial impregnated catheters are effective. So he reviewed 19 randomised case controls. He looked at the CDC recommendations, and he found and made these recommendations from his own publication here. He said that of the 13 of the 17 published studies that he'd reviewed showed that these impregnated catheters either showed a statistically significant reduction or a strong trend towards reducing rates of bloodstream infection. And I believe that that's a fairly strong statement. He also, at that point, said that 40% of intravascular device-related bloodstream infections were preventable, although subsequent work by Pronovost and others around Michigan and some of the other US states has now suggested that rate's a whole lot higher. And I know even in Australia we have a couple of hospitals that have had and been able to maintain 100% reduction. So naturally, all of those studies and Dennis's work and the grouping of great minds, both here in Australia and overseas, allows us the luxury now of some fabulous current recommendations. And these are both great examples of guidelines that exist and should help us in our practice. I'll look at the recommendations regarding impregnated catheters from both of these documents. The 2011 CDC guideline has commentary on both the antibiotic impregnated catheters and also around those that are coated with antiseptics, so chlorhexidine and silver sulfadiazine. They also mention platinum and silver catheters, but there's less evidence that supports their use in CDC's mind. So CDC came out with this strong recommendation, which was these catheters should be used when an adult has a central line in place that is expected to remain there for longer than 5 days if other comprehensive strategies have failed to reduce the rates of catheter-related bloodstream infection. In my mind, our failure to reduce catheter-related bloodstream infection is if we get less than 100% reduction. And that's because I know that some hospitals have been able to get that 100% reduction and sustain it. CDC say that the comprehensive strategies that they expect hospitals to follow would be education of people who are inserting, maintaining, accessing these devices, and also use of maximal barrier precautions at insertion and the use of at least 0.5% chlorhexidine at insertion. Now, we know from the work of the ANZICS group, published by McLaws and others, that we haven't yet gotten to 100% in terms of compliance with those issues. So it's a good thing we have technology on our side. These are the recommendations from the ANZICS document. I know that you'll be well familiar with them, and I think it's great to see this comment particularly, that if a patient has a hypersensitivity reaction or has known sensitivity, don't use it. But it also says that hypersensitivity reactions to chlorhexidine-coated central lines have been reported, albeit rarely. And rarely is a really important word because I believe there's some misconception of how risky chlorhexidine is. And I now want to spend the remaining few minutes talking to you about this. Chlorhexidine, do we defriend it or do we defend it? To me, it will be a friend for infection prevention, hopefully for as long as my career continues in this field, because it's been so widely used since 1970s as a great antimicrobial agent. In fact, it's used widely in domestic things that we wouldn't even think about, so contact lens solution being an example. It also has been widely used in urinary catheter insertion, both as an antiseptic for preparation with as part of quad ammoniums. It's also included in some lubricants and previously had been in implanted meshes, surgical meshes. We've started to see an increase in its use in clinical settings, so both in skin preparation and as an active ingredient in many of the hand hygiene solutions. It has broad spectrum action, important for those gram-positive and gram-negative organisms. It's rapidly acting and it has persistence. So it can continue to kill for a period of time, unlike other antiseptic agents. But to use it, just as we use any other solution, we have to make sure that we do that safely. And if a patient has a known sensitivity, then clearly we wouldn't expose them to chlorhexidine. But typically, the reactions that patients have are rare, and they're typically minor. And when I first started looking at this issue, I thought, if we have so much chlorhexidine out there, and it really is this people are purporting that it's this big, scary, anaphylactic causing agent, then why are we not seeing staff who are continually using it in hand hygiene solutions, only 80% of the time they should be, but they're still using it a lot? Why are we not seeing those staff have reactions to chlorhexidine? So I'm thinking something just doesn't gel in this picture, and I wanted to try and understand it. But as for any device, it always has to be used as the manufacturers instruct. And so a sensible clinician who uses devices, I guess, would make sure that they were familiar with what those warnings are. But there have been anaphylactic cases reported, and I'm not disputing that fact at all. And I don't want to be one of the people who have anaphylaxis from it, but I think that my odds of that happening are quite rare. These anaphylactic reactions occurred about 20 or so years after chlorhexidine had first been introduced, and most of the adverse reactions were not anaphylactic but were mild skin reactions, and they've been reported for about 30 years or more. The first report of a type 1 hypersensitivity was in 1984, and then subsequently there'd been about 50 case reports. Now, the highest rates have been reported in Japan, and so perhaps there's some genetic predisposition amongst Japanese. Most of the anaphylaxis has been reported during anaesthesia and surgery. And there are several things that happen in surgery, particularly in patients that are having central lines associated. And what happens is that as the patient lies there on the table, vulnerable at the beginning of the surgery, people come to different parts of their bodies, invading them with chlorhexidine. And if you read this literature very carefully, and the list of references is at the back, you're more than welcome to a copy of this presentation, you'll see that the majority of these reactions have occurred when patients have also had urinary catheters inserted with chlorhexidine containing lubricant. And then they've gone on and had insertion of an impregnated central venous catheter. In the multi-case series, that's certainly been the type of reaction. So it's been after urinary tract mucosal contact with chlorhexidine versus insertion of an impregnated catheter. There have been, however, a set of specific reports of reaction to chlorhexidine impregnated central venous catheters, and I'm not disputing that, but they are rare, particularly when you line them all up and have a look at them. And in these cases, most often the chlorhexidine sensitivity was known prior to insertion, which brings me back to the point of how critical it is for us to read the documentation and understand the packaging and the labelling warnings. This could be interpreted by people in one way, and it comes from 2009, where 4 cases of anaphylaxis to chlorhexidine impregnated central venous catheters, a rare case cluster or the tip of an iceberg. I'd read this letter if you had a chance to do it. But what to me is most important is that of the 50 cases reported over 10 years of anaphylaxis, the majority of them were not central venous catheter related. And you need to read that carefully. So as clinicians, and it's just to show you that occasionally I do get into the intensive care world, what are our responsibilities? Our responsibility is checking the packaging and taking a good patient history. So we want to know what the devices are that we're using, but we also want to know whether the patient is predisposed. And if you read this paper carefully, reported in 2001, this was the commentary from the authors. It was not widely appreciated that central lines may be pre-coated with chlorhexidine, and that line was handed to us already open, so none of us thought to check the package insert. So I admire these authors for their honesty in putting this up, but I also shook my head. They also acknowledged that chlorhexidine impregnated central venous catheters are contraindicated for patients with known hypersensitive, as they should be. So a lot of concern around it, perhaps some misinterpretation of information, and perhaps the systems don't exist for us to fully understand and appreciate these reactions. But nevertheless, politicians react strongly and often, and in the United Kingdom they put out a medical advice alert at the end of 2012. But really what it says is be aware, ensure that patient allergies are known and recorded, check the labels and the packaging. If the patient experiences an unexplained reaction, check whether or not chlorhexidine was used, and think about urinary catheterisation, think about skin prep, and whether or not an impregnated device is being used, and then report the reaction. And I hope that in Australia, if there is this type of reaction to urinary catheter lubricant with chlorhexidine or skin prep, I hope that it is being reported so that we can get a balanced view of this issue. Because there are some recent national concerns regarding chlorhexidine, and some of you may have seen this video. If you look at the data, it's not based on scientific evidence that I can find. There's some random use of it, but these issues are of concern, and I think we need to really understand the problem. So my recommendation is read the scientific literature rather than be swayed necessarily by popular opinion. Realise that not all anaphylaxis has been associated with the use of central venous catheters, that ultimately there has to be a risk made around the opportunity cost, and that opportunity cost is the risk of infection, of serious central line associated bloodstream infection, which affects 3,500 Aussies every year and kills 35 of them, versus the risk of anaphylaxis. And so for a balanced view, our CLABSI efforts have to target all of the potential sources of infection, and they're listed there. You're well aware of them. I know that you will walk out of here and go back next week to the hospitals and be fully compliant, and I hope you continue to do that. I hope that you follow the CVAD post-insertion management guidelines if you work in New South Wales, where they are recommending chlorhexidine use, and they see it as being a safe and protective thing. Because the current thinking around anaphylaxis is that these reactions are rare, but they are being reported increasingly in association with a variety of products. So we need chlorhexidine to help us reduce healthcare-associated infections, and it has the potential to sensitise a very small proportion of patients, and it may lead to anaphylaxis on subsequent exposure. This is how it happens, through exposure, sensitivity, delayed reaction, mainly minor cutaneous reaction, subsequent exposure, and then anaphylaxis in those that are predisposed. So, impregnated catheters, do they work? As we think about that opportunity cost, we have to think about their effectiveness, and certainly we see from these studies that there are far fewer organisms at 28 days that are colonising impregnated catheters compared to those that are not impregnated. So there are outstanding questions around this in 45 minutes, and with people finishing all around me, I can't answer them for you, but perhaps you can. The question that I find most curious is the genetic predisposition to chlorhexidine hypersensitivity. I also wonder whether the true incidence of chlorhexidine anaphylaxis from urinary or from skin preparation or from impregnated devices, whether we know that true incidence. It'd be great if we could have a more robust reporting system so we could clearly find out where those causes are. The question of why healthcare workers show no greater incidence astounds me, and I will never understand why clinicians fail to take the preventative actions when most cases, in examples like this, they've previously known chlorhexidine sensitivity. So the psychology of healthcare and the whole issue around human factors and systems that continue to fail us is a really interesting research question. I've asked you to do an opportunity cost, and I tried to make this point last week with lottery, but I've actually gone from a different angle this week, just to keep it interesting. These are your odds of dying according to different things. Your odds of dying from a flesh-eating bacteria are about 1 in 1.2 million. Your odds of dying in an aeroplane crash are about 1 in 700,000. Your odds of having a catheter-related bloodstream infection if you have a central line are 1 in 100, so they're much higher. Your odds of having an anaphylactic reaction to a chlorhexidine impregnated central line are about 1 in 1 million. So they're up there with you dying from a flesh-eating bacteria. So I'll let you think about that. Take it away. I hope you don't sit next to someone with a flesh-eating bacteria in an aeroplane that hits turbulence this afternoon. Because what I want you to do is go back to your hospitals, take very careful medical histories. Don't use chlorhexidine impregnated central venous catheters in patients with known hypersensitivity. Be familiar with all products and labels you use. And if someone has an anaphylaxis, what better place to have it than an intensive care unit or an operating theatre? But as you're doing your blessing or whatever you do, because that's where they are, immediately withdraw that catheter. And I don't want to make summary of that, don't want to make humour of that, but get the catheter out as quickly as you can. Anaphylaxis is serious, we need to avoid it. The risk is small. Of 30 million units sold worldwide, there's been about 2 cases per million units. CLABSI in Australia is a much more important issue in my mind than anaphylaxis from these devices. We need to get the return on investment that ANZICS and the infection control community, all intensive care unit physicians and nurses have invested in the last few years, and greater compliance and the concurrent use of wonderful technologies and those that will evolve is the way that we can do that. I wish you good luck, and I thank you sincerely for the work that you've been doing around preventing CLABSI. It makes a big difference, and I want you to be my friends. Chlorhexidine remains my friends. Here's the readings. If you ever want to have a discussion with me or an ongoing debate, find me, and yes, I am on Facebook, and that's how you can do it. So thanks very much, guys. Have a great day.